Hello everyone, today we'll be discussing leukemias. Leukemias are a heterogeneous group of hematologic malignancies that arise from the dysfunctional proliferation of developing leukocytes. Leukemias are classified as either acute or chronic, that is based on the rapidity of the proliferation, and as myelocytic or lymphocytic, that is based on the cell of origin. So we need to know that it's either based on how fast they are dividing, so that's either acute or chronic, and then we need to know what cell origin is affected, so is that myeloid or lymphoid, okay? The production of abnormal leukocytes defines leukemia as either a primary or secondary process. They can be classified as acute or chronic based on the rapidity of the proliferation, and myeloid or lymphoid based on the cell of origin. Predominant subtypes are acute myeloid leukemia, chronic myeloid leukemia involving the myeloid linkage, and acute lymphoblastic leukemia and chronic lymphocytic leukemia. These involve the lymphoid lineage. Then there are also other less common variants such as the mature B cell and T cell leukemias and NK cell related leukemias. Acute versus chronic myeloid leukemia. Blasts, which are immature and dysfunctional cells, normally make up 1% to 5% of marrow cells, okay? Acute leukemias are characterized by greater than 20% blasts in the peripheral blood smear or on bone marrow, leading to a more rapid onset of symptoms. In contrast, when we talk about chronic leukemia, these have less than 20% blasts with a relatively chronic onset of symptoms. The accelerated blast phase is a transformation of chronic myeloid leukemia into an acute phase with a significant higher degree of blasts. So as such, we discussed the four major subtypes of leukemia. Acute lymphoblastic leukemia, which is ALL. This is seen in patients with the blastic proliferation of B and T cells. It is the most common leukemia in the pediatric population, accounting for up to 80% of cases in this group versus 20% of cases in adults. Treatment among adolescents and young adults is predominantly inspired by the pediatric regimens that have a better survival rate. So we need to know that acute lymphoblastic leukemia is more common in the pediatric population. Acute myelogenous leukemia (AML). This is characterized by greater than 20% myeloid blast and is the most common acute leukemia in adults. It is the most aggressive cancer with a variable prognosis depending upon the molecular subtypes. Chronic lymphocytic leukemia (CLL). This occurs from the proliferation of monoclonal lymphoid cells. Most cases occur in people between the ages of 60 and 70 years. CLL is considered an indolent disease for the most part. That means that not all patients with a diagnosis will need to start treatment until symptomatic from the disease. Chronic myelogenous leukemia (CML) typically arises from reciprocal translocation and fusion of the BCR on chromosome 22 and ABL on chromosome 9. That results in dysregulated tyrosine kinase on chromosome 22. That's called the Philadelphia chromosome, which is the PH chromosome. This in turn causes a monoclonal population of dysfunctional granulocytes, predominantly the neutrophils, basophils, and eosinophils. Etiology. So there are multiple genetic and environmental risk factors that have been identified in the development of leukemia. Exposure to ionizing radiation is associated with an increased risk of multiple leukemia subtypes. Exposure to benzene is a risk factor for leukemia in adults, and particularly acute myelogenous leukemia. Previous exposure to chemotherapy, especially alkylating agents and topoisomerase II inhibitors, these increase the risk of acute leukemia later in life. Then, a history of any hematologic malignancy is a risk factor for subsequently developing another subtype of leukemia. Viral infections such as infection with human T-cell leukemia virus, which is HTLV, Epstein-Barr virus are linked with subtypes of acute lymphocytic leukemia. Then several genetic syndromes such as Down syndrome, Fanconi anemia, Bloom syndrome, Li-Fraumeni syndrome are associated with an increased risk of acute myeloid leukemia and acute lymphocytic leukemia. Pathophysiology. Leukemia occurs due to the malignant transformation of pluripotent, which is it can give rise to both the myeloid and lymphoid precursors, hematopoietic stem cells. Rarely, it can also involve a more committed stem cell with limited self-renewal capacity. In acute leukemias, these malignant cells are generally immature, poorly differentiated, abnormal leukocytes which are blasts that can either be lymphoblasts or myeloblasts. These blasts can undergo clonal expansion and proliferation, leading to replacement and interference with the development and function of normal blood cells, leading to clinical symptoms. When we talk about acute leukemias, in acute lymphocytic leukemia, chromosomal translocation or abnormal chromosomal numbers can lead to mutations in precursor lymphoid cells, leading to lymphoblasts. Common mutations include T1221 and T922. In acute myelogenous leukemia, chromosomal translocations, rearrangements, and gain or loss of chromosomes can lead to mutations and abnormal production of myeloblasts. Chronic leukemia, chromosomal abnormalities in hematopoietic stem cells that are precursors to leukocytes are the most common cause of chronic leukemia. Examples of the abnormalities include deletions, translocations, or extra chromosomes. In chronic myelogenous leukemia, mutations mainly affect the granulocytes, which is most commonly the T922 translocation, and in chronic lymphocytic leukemia, they primarily affect lymphocytes, especially the B lymphocytes. However, we need to know, unlike acute leukemias, in chronic leukemia, cells are partially mature. These partially mature cells do not function effectively and they divide too quickly. So this leads to the accumulation in the peripheral blood and lymphoid organs, which can lead to anemia, thrombocytopenia, and leukemia. Histopathology. In acute leukemia, the peripheral blood or bone marrow is characterized by more than 20% of blasts. There is usually increased cellularity that is noted on bone marrow biopsy that is packed with blasts and a variable number of granulocytic or monocytic cells and erythroid precursors. Common T-cell lymphoid immunostains include the TD22, CD2, CD3, CD5, and CD7. However, the traditional markers that are included in the evaluation of acute leukemias are CD7, CD11b, CD13, CD14, CD15, 16, 33, 34, 45, 56, 117, and HLA-DR. Then we also have mixed phenotypic leukemias. So these both have myeloid and lymphoid markers. However, this is a rare entity. Then cytogenetics evaluation for Philadelphia chromosome status and Philadelphia-like translocation is a must, as newer therapeutic agents are now incorporated into treatment algorithms. Chronic leukemia. The white blood cell count in chronic leukemia is often elevated with a smear suggestive of significant left shift or granulocyte predominance. Such a picture is commonly seen during the acute illness phase, but if such a picture persists upon repeat labs, chronic myeloid leukemia should be evaluated. In CML, the translocation T922 can be diagnosed by FISH, which is the fluorescence in situ hybridization on peripheral blood. Bone marrow biopsy is not necessary for diagnosis, but if done, it's going to show 100% cellular marrow with increased granulocyte precursors, basophils, eosinophils, and occasional monocytes. And flow cytometry is often a diagnostic test for chronic leukemia. History and physical examination. Acute leukemias, these tend to present non-specifically. Although when we look at the features, the most common presenting features include fever, lethargy, and bleeding. Hepatosplenomegaly, lymphadenopathy, and musculoskeletal symptoms, especially those involving the spine and long bones. This can also be clues to the diagnosis. Adults may also have more prominent anemia-related symptoms such as shortness of breath or symptoms related to thrombocytopenia, which include excessive bruising or increased bleeding tendency. Patients with acute promyelocytic leukemia, which is associated with DIC type symptoms, can present with mucosal bleeding, including gum bleeds, nosebleeds, or menorrhagia. Chronic leukemia subtypes occur almost exclusively in adults. Many patients are asymptomatic at the time of diagnosis. They are only identified incidentally after marked leukocytosis is discovered on a complete blood count that is performed for any other reason. Hepatosplenomegaly and lymphadenopathy can be appreciated in some cases, while bleeding and bruising are less common, presenting features relative to acute leukemia subtypes. Evaluation. The workup of leukemia is very involving, so multiple tests are needed to confirm a diagnosis and subsequently also to stage the disease. So for initial studies, we can begin with a complete blood count, comprehensive metabolic panel, liver function test, and coagulation panel, which are often followed by peripheral blood smear evaluation and a bone marrow biopsy and aspiration. On rare occasions, however, leukemia can be diagnosed on histology alone. For example, acute myelogenous leukemia is characterized by the presence of rods, which are the red staining needle-like bodies seen in the cytoplasm of myeloblasts on a peripheral smear. In most other cases, more detailed analysis with flow cytometry, cytogenetics, and FISH testing are required to distinguish between the various subtypes. A bone marrow aspiration and biopsy are often required for the diagnosis of acute leukemias. For chronic leukemias, peripheral blood evaluation is often enough, and an invasive bone marrow biopsy may not be needed. For example, chronic myelogenous leukemia can be diagnosed by looking for the BCR-ABL fusion protein on peripheral blood FISH analysis, and chronic lymphocytic leukemia can be diagnosed by looking for a monoclonal B cell population through peripheral blood flow cytometry. Therapy and management. Therapy varies significantly, that's based on the leukemia subtypes and patient factors. Acute leukemias are treated predominantly as an inpatient needing significant support, frequent monitoring of vitals, and assessment of opportunistic infection and electrolyte imbalances. The predominant challenge at the time of diagnosis of acute myeloid leukemia is to identify the possibility of APL, which has a significantly different treatment compared to the rest of acute myelogenous leukemia. For APL patients, they typically present with bleeding diathesis with increased coagulation parameters and low fibrinogen. Peripheral smear shows a predominance of myeloid blasts with rods. It's important to start the treatment with ATRA, which is the all-trans-retinoic acid, when APL is suspected, instead of waiting for confirmatory tests. APL patients have a better overall survival and prognosis than other types of AML without needing a transplant. AML, the standard therapy, which we call the 7+3 regimen. So this includes a 7-day course of cytarabine continuous infusion with a 3-day course of an anthracycline, which can include either daunorubicin or idarubicin, with the advent of cytogenetics and NGS testing. Patients are now being risk stratified based on the molecular markers that result in prognostic and therapeutic implications. Then, for the treatment guidelines, we use the European Leukemia Net. Acute lymphocytic leukemia, this is divided into B or T lymphocytes variants that is based on the lymphoblast origin and the presence of more than 20% of lymphoblasts in peripheral smear or bone marrow. The presence or absence of the Philadelphia chromosome is the most common molecular marker leading to therapeutic implications in treating ALL. The overall outcome depends upon the patient's response to induction therapy and the presence or absence of MRD, which is minimal residual disease, that may need further therapies or bone marrow transplant. Chronic myeloid leukemia is one of the first cancers that is revolutionized by utilizing targeted therapy with Philadelphia chromosome targeting, tyrosine kinase inhibitors. Patients have a significant response to TKIs, negating the need for acute chemotherapy unless they are in an accelerated phase of blast crisis. Then follow an intermediate risk patients, imatinib can be initiated as first-line therapy. Chronic lymphocytic leukemia runs its course in a more indolent fashion than all other leukemia subtypes, with the patient's lifespan minimally impacted by the disease. Patients do not benefit from early treatment unless they meet the criteria for therapy. So patients with a rapid doubling time of lymphocytes, worsening cytopenias, increasing spleen size causing abdominal discomfort, and significant B symptoms which include fatigue, night sweats, and weight loss benefit from treatment. The most important determinant in treating CLL is knowing the IGVH mutation status and the presence of DE117P and TP53 mutation. Complications include tumor lysis syndrome. So this is a complication of chemotherapy that can result when tumor cells die quickly. The widespread cellular destruction releases intracellular contents into the bloodstream, overwhelming the kidneys and resulting in dangerously high serum levels of potassium, phosphorus, and uric acid. In such cases, patients need aggressive hydration, frequent lab monitoring, and management of hyperuricemia with allopurinol. Hyperkalemia and hypocalcemia can lead to significant cardiac toxicity, therefore they need to be corrected urgently. Disseminated intravascular coagulation. This is a complication of leukemia itself in which the proteins that control the blood clotting process become dysfunctional. That leads to both thrombosis and hemorrhage. DIC is often associated with acute promyelocytic leukemia but can be seen in other subtypes of leukemia as well. Frequent lab monitoring with active replacement of fibrinogen and with cryoprecipitate is vital to the patient's survival. Then infection, immunosuppression from chemotherapy, stem cell transplantation, or leukemia itself increases the risk of dangerous infections. Fever with neutropenia in an immunosuppressed patient should prompt an immediate evaluation for infection source and the initiation of broad-spectrum antibiotic therapy. Cancer. Survivors of leukemia are at an increased risk of subsequent cancers. For example, the Childhood Cancer Survival Study demonstrated that the 30-year cumulative incidence of any cancer after leukemia was 5.6%. The most common second neoplasm in childhood leukemia survivors are different subtypes of leukemia or lymphoma. This is basically a summary of what we've discussed. This is my reference. If you like the video, please like, subscribe, and comment. Thank you.